organizing the day and pulling the speakers together. So I'm going to kick us straight off with our first speaker, Dr. Annalisa Casarin, who is a senior research fellow at the University of Hertfordshire and a part-time senior research advisor for the Research Support Service at the University of Leicester Hub. She's the principal investigator for a National Institute of Health Research funded project, which is exploring policies and practice related to access to services for people with rare diseases. And as some of you may remember, Annalisa was also at PSPA working as our research coordinator in 2022 and 2023. So some of you will have met her when she had that hat on as well. But lovely to have you back, Annalisa, and I'll hand over to you.
Thanks so much. Can you hear me?
Yes.
Yeah, good. Yeah, great to be here. Thanks so much for the invite, and yeah, excited as well to talk in a different capacity. Shall I share my own slides, right? I think that was the plan.
Yes, please. That would be great.
Let me know when you can see them, please. So, and if it's like big enough, you should see something coming up.
There's definitely something starting, but at the moment we've just got a black screen. And I can see your cursor.
Okay, but still on a black screen.
Yeah.
Okay, so let me try again. Okay, sure. It's still black.
Yeah, at the moment. Do you want to send them to me quickly so that I can share them for you?
Second. Yeah, I'll do that. And I'll try it again. So the beauty of technology.
Best to get the technical difficulties out of the way at the start.
So we got this one and this. Okay. Trying to close it 1 second. Well, we still have some minutes ahead of time.
We're a little bit early.
Yes. I'll try again anyway. So I send it to you now.
Maybe would it help for me to just introduce myself very briefly, because I'm going to be supporting Annalisa with her talk. So I'm very new to the ImproveAPS project, which is its shorter name, and I'm very honoured to be working with Annalisa, who knows the field far better than I am, but I will be presenting some of the slides, which will appear shortly.
Yes, I would have said that with the first slides that I guess is still black, is it?
Yes, it is.
Sorry about that. I don't know why. Anyway, I'll try another way.
So for the lady who just spoke, do you want to rename yourself on Zoom? Because at the moment you're VN25.
Oh my goodness, yes. Let me see if I can work out how to do that. Rename, yes.
Yeah, so
I shall do that straight away.
Thank you.
Yeah, so I introduce actually Vicky. Vicky Nichols is Senior Research Assistant. Let me try this. No, even,
there we go.
Yes.
Yes.
You got something.
There we go.
And another question. Do you see just the slide or also the next slide?
No, you're in full screen.
Just
good.
Perfect. Okay, great. So yes, again, my name is Annalisa, and I will talk about this study that just started in March and is funded by the National Institute of Health and Care Research. And with me, we got Vicky, that is our Senior Research Assistant. Thank you for filling in the gaps. The study will be presented in a way that is ongoing. So we don't have results yet, but at the moment we want to tell you about it and why it's important to look at the system of care and what we want to do, examples of research and when this actually made changes in practice, and how to get involved. And of course, there will be the Q&A session at the end. So the full title is a bit long and complex, but I will try and go like slow and show all the components. So the full title is Co-Designing Improvements to System of Care and Support to Tackle Inequality of Access for People with Atypical Parkinsonian Syndromes. And this will be done combining a system approach and realist review to inform a discrete choice experiment. All these are research tools, so it sounds complex, but again, I will explain a bit. We know that CBD, PSP with MSA are part of something called atypical Parkinsonian syndromes. And also we know that there is a plethora of names for these conditions, and this may create some complexity as well. So they could be called atypical Parkinsonian syndromes, but also atypical Parkinsonian disorders. So people may know them in different ways. And together are rare conditions that affect around 15,000 people in the UK. But of course, we got also carers, professionals looking after them, so they do affect even more people. And we know that are often confused with Parkinson's because they have similar symptoms, and this may create some issues with diagnosis. So the problem is that we got a quite high percentage of misdiagnosis at the beginning and delays in proper care, with an average time of delay of 3 years. And there is lack of equal access to services because across England, across actually UK, we got specialist care and support groups. They are not evenly distributed. Some information from other research, early research about PSP and MSA demonstrated that even like in 2013, there was lack of essential care for people with this condition, especially those far from major centers. But PSPA and the MSA Trust surveys show that after post-COVID, the situation didn't get any better. 30% of responders reported delays in accessing health and care support, and 70% stated they didn't have any care plan in the last 3 years. So we have a group of researchers and clinicians based in different organizations in the UK, and we want to explore the diversity of experience of people with APS and their carers. And also, I can add here the professionals and the experience they have with accessing health and care services. We want to understand the context and the complexity of provision of these services in specific location in England, and this in order to create context-specific recommendations. So we talk about context, and that is basically the whole system of support that includes healthcare, social care, community care, care at home, private care, care homes. So there is quite a wide and broad involvement of several professionals, and we want to hear from them as well. And this is because we want to unpack the complexity of providing services. The complexity is due to the fact that there are different needs. Everyone is different with different needs and different stages of the condition. There are multiple providers with different funding and budgets that they can make use of. There are policies that they need to be, let's say, attentive of, and they need to abide to laws and policies. And of course, there are workforce challenges where there are like shortage of staff, but also they work under pressure. They need to know a lot about many conditions that they may not be aware of some. And then, of course, there are some cultural language differences across the system, and technology innovation can help, but also can provide inequality if people are not technology experts. So what we want to do is to apply something called realist approach. This is, again, a research tool that help us to assess how the intervention in a complex situation works. If we call services the interventions, Then we want to understand how and why these services works in specific contexts. The realist approach emphasizes the fact that one size does not fit all, and so we need to understand what works in which situation and for which people, the different people they are involved. So it does examine the conditions that are needed for a particular intervention or mechanism or service to work. And the result of a realist approach used in research is more useful to policymakers. And also we want to look at the system because, as I mentioned, there are multiple stakeholders. We want to look at the design, the processes, and also the risks attached. So we want to look at the good examples in some locations, learn from them, and then ask other locations or like suggest them to actually make some improvement. And we're doing that first understanding the problem. So we look at what is actually going on in practice. And then we will create virtual but visual map of all the systems involved. And then there will be another research tool that will help us to ask people their preferences, what they prefer the service to provide to them. So we are now at the stage where we are trying to understand the problem. So we are looking at policies, the guidance. There are some there, but again, they're not maybe used in the same way in different locations. They're not yet quality standards, but the aim is actually for this project to, let's say, make contribution to create quality standards. And we want to look at models of care where primary, secondary, social care are integrated. We will start potentially in autumn, winter, depending on ethics, recruiting for interviews. We want to get 24 cases to look at their trajectory and the services they accessed. And so far we got around 20 expression of interest. So it does look quite good. We're going to be able to recruit people for that. And then we will going to discuss the results with in 3 focus groups with the professionals to actually understand their perspective, what they think is working well and what needs improving. Just quickly, I wanted to show which are the questions we may ask during the interviews and the thing we discussed during the focus groups. And is about access to services. And we can break down this in few, let's say, point for discussion. So are services there in the first place? Are people actually using them? Or what stops people from using them? And do this service lead to better health? And of course, quality of life, better quality of life. This is again an example where this approach made a real impact. It's a complex slide, I'm sorry, but it was just to show how complex is the problem. So it's not just about, well, I know the service is there, I just go call and go. And you have this experience, I'm sure, where the service needs to be first approachable, needs to actually provide the appropriate care or the care you need in the right time, needs to be available, and needs to be affordable. So there are many aspects we can look at, and also there are many points where we can make suggestions for improvement. An example of, again, something that was, let's say, where people were involved since the beginning to provide their experience and their everyday challenges is a project that was delivered by our colleagues in the ARC, Applied Research Collaboration in East of England. And in the small bullet points, we can see the recommendation, or like first the challenges they identified and then the recommendation. So the need for more integrated holistic care, improved communication, better coordination, highlight the importance of mental health support, identify several systemic challenges like logistical barriers, transport, and then they provided practical solution for all these challenges. And this is what we're going to aim at. And this is another example, again, recently completed. They're very successful. And Vicky, if you don't mind to present that.
Certainly. Thanks, Annalisa.
Thanks.
So this slide and a couple of slides after it are about a study that was called, or has been called, the MIND study, and that's been carried out by some colleagues of ours and other people based in the Norfolk and Suffolk NHS Foundation Trust. This has taken a realist approach, which, as Annalisa says, is a particular tool used in research. I think what's particularly important about this project is that they co-produced everything. So lots of different people worked together to make the research happen. The aim of the research was to improve mental health discharge planning from the viewpoint of everyone involved, including people with lived experience. That would be, in this particular example, with lived experience of mental health issues, but that can apply to other people's experiences too. Also from the points of view of the supporters of those people with the issues and staff. So as I already mentioned, this was an example of co-produced research, which means that researchers work together with people affected by the research, like patients, community members, service users, or frontline staff, as equal partners throughout the research process. Okay, so what they did with this study was they identified the challenges and what might work within the setting. So similar to what we're aiming to do, but in a completely different context. And together they co-produced something called, I think this is a lovely name, the onwards approach. So clearly that can be said as either onwards or onwards. So it's a bit of a play on words there about what can be the best practice for people being discharged from hospital wards. And this approach that they co-produced, is a multi-component intervention, providing a holistic, adaptable and person-centred practice. And it included these different components, the onwards planner, a supporter planner, supportive practice, gradual leave, that's people being discharged gradually, and mini teams. What they then did was they tried applying the onwards approach within 3 different mental health trusts locally to their area, and they're now analysing those findings. But the early findings that they have been able to share is that this approach can improve discharge planning, and the hope is that that will improve discharge outcomes, such as reducing readmissions, and in the longer term, that might help to reduce pressure on inpatient services. And again, although this is in a mental health context, it has clear applications in other contexts too. Coming back to the ImproveAPS study, which is what we're here to talk about, obviously, there are different ways in which people, including hopefully people here, and as Annalisa already mentioned, we have 21 people who have already come forward to take part in interviews, which is the first way that people can participate in the research. And those interviews, which will be undertaken with 24 people, and those will be pairs of people living with one or another of the conditions that we're talking about and their carer. And those interviews can happen either virtually or face-to-face, depending on what works best for the people being interviewed. And then the transcripts from those interviews will be reviewed. And then there'll be a further opportunity for people to participate in a workshop. We're going to have a series of workshops, and those will review the findings and look at the best ways forward. And for anybody that takes part in any of that, the time for carers and all of people's expenses will be reimbursed. Just to touch briefly on public involvement in research, because that's one of the ways that we are working with the ImproveAPS project. And as you may know, of course, you have your own public involvement in research groups, so of course you will know about this, I'm sure. But the group that we are just setting up doesn't have a name yet, but anyway, we've had our first meeting, which was really, really good, and people had lots of exciting ideas for how the research can be taken forward. Overall, what public involvement in research means is that people with relevant experience, they may be patients or they may be other people, contribute to how research is designed. And with the ARC example, I'm sorry, I'm talking too fast, that Annalisa touched on earlier, it's ideally people are involved throughout the whole process. So that does require some quite creative thinking about how people can be involved in designing the research, conducting the research, and disseminating the research. And it's been found that research teams that involve patients and the public run better studies because it hopefully means that the studies are designed to suit patients rather than maybe the researchers. It means that people who are at the forefront of knowing what it's like to live with conditions can help us to find and reach out to the best audiences for research. The researchers can communicate in the best ways possible, and also those groups can help us to identify ways to measure outcomes, and there might be all sorts of different outcomes. Different people might find different outcomes more important. They can also help to provide the best solutions for patients, which is what it's all about, and they can help us to share the results of research. So for this study, there are different ways in which members of our group, which I think has parallels with your group, will initially provide insights based on their experience, and they're going to do that in different ways throughout our research. The first thing we're going to be doing in the autumn, over the summer and into the autumn, sorry, is a literature review of existing published evidence. And that's going to be evidence that's been published in all sorts of different places, including academic literature, but also in newsletters, also maybe on blogs and in charities, on charities' websites, different ways that evidence has been published about what services there are for people affected by CBD or PSP or MSA, what challenges people face in accessing those services, where to look, what to ask, and what you know about services. Secondly, our PPI group members will be involved in the recruitment and sharing the results of interviews and focus groups with patients, carers, and professionals. They will be thinking with us about what to ask, how to interpret and summarise results. And then finally, people from that group for this stage of the research will be involved in mapping the system of care, which is one of the stages which is crucial for us to be able to then hopefully influence services locally. That means that people will have better access to the support that they need. And finally, people will participate in dissemination activities.
Thank you. Great.
Thank you.
And so, yes, we just wanted to share this is happening, and we're excited about this, and especially because the government is paying attention, they actually fund it. And so we are really enthusiastic of the fact that this will potentially, but I'm sure it will change practice further on. If any question, we are here.
So I might kick it off, Annalisa, by asking the question about, once this project is finished, how ideally would you like to see its results have an effect on what is happening out there?
Yes, thank you. So I mentioned that access of service to services is quite a complex, let's say, thing. And so we are trying to address all those issues that could be about the availability of service, or like the awareness of professionals of which services they need to refer people to, and provide some resources for actually people to be able to access those. And also sometimes you need a sort of communication tool. For example, some patients may not know the trajectory of their condition. They may know what is going to be ahead, and what will need to be triggered in order to support them. And this tool could be co-created, again, understand if there is, I don't know, the need of a like personal plan or personal communication tool that people can carry on at each visit, where they got all the information about their condition at the moment and the potential services they need. And this will also trigger maybe GPs to be more attentive of what the future needs will be.
And does your funding cover creating some of the materials that you identify are missing, or would you be looking for organizations like PSPA to work with you on that? Because having worked with us, you know we've already got quite a lot of materials, but clearly you're going to identify gaps. Who will actually fill those gaps?
Yes. So at the moment we got this grant from the NIHR, National Institute of Health Research. And I think it is not just about guides or like guidance. It's more like maybe digital tools can be, or like something on paper, like a different tools that will be co-created again. And we are already planning to get a second grant, like to apply for a second grant to actually develop an intervention. So the intervention is not just guidance or tools, but actually going into localities and show them how maybe the system could be organized and in way processes will be streamlined. For example, the GP could request a urgent referral instead of like being put in a waiting list because there's no clear diagnosis. So there are many ways where actually this can be improved. And well, PSPA will be one of the potential source of funding. So we will actually apply for one of the grants coming up. And also we will go back to NIHR as well.
Thank you. Rebecca, Megan, any other questions from you?
So Annalisa, you say you've sort of had 20 expressions of interest already. Are you still interested in people coming forward? And you may have mentioned it and I may have missed it. Is there some set criteria that you'd say for these reasons it's better if you come forward, or for these it's not?
Yes, like every research study has some inclusion exclusion criteria, but we hope we will engage with everybody coming forward. So we want 24 cases to be representative. Let's say if the condition is already known, it will be that the person, they are already within like 3-4 years into the care trajectory. And of course, the more experience with services and the challenges they have, the better. But there are many ways they can be involved anyway. For example, the workshops give their view on that, the PPI group. And we're really grateful. We got already 5 people there with a mixture of PSP, CBD, and MSA conditions. So yes, whoever is interested, we're here to listen from you and not to exclude anybody, but find a way to actually engage with all.
So carry on, Rebecca.
Rowena was just asking about resources. I guess what would be your ideal outcome? Where would you like this to lead?
Well, there will be like engaging with commissioners, and so really, and potentially the government to really understand these people, like the patient affected, but also carers and professionals do struggle at the moment. And there needs to be more focus on people with rare conditions, because they are the one that struggle the most within the all, say, conditions at the moment. We know NHS resources will be tighter, unfortunately, going forward. So we don't want to reinvent the wheel. We don't want to suggest something that is not, let's say, feasible or not implementable. We want to actually talk with them to say, look, maybe here you over seen something that you can improve without much, costs for NHS and social care, and especially the social care aspect as being quite neglected in a way, or overseen, again, not fully understood. So we do have suggestions already how this can be made better.
Thanks, Rebecca. So we have a comment, or maybe a question from Phil McCarthy. From discussions in our support group, initial information concerning sources of help, such as PSPA, is not provided by the diagnosing neurologist. So simple leaflets signposting PSPA would be extremely useful. Is that the type of thing you can see might be an outcome of your work?
Yes, definitely. And actually, we're grateful for PSPA and MSA Trust. They're both involved, and they will both be represented in our steering group. So yes, definitely that will be one of the options. within the solutions we want to provide, and again is part of awareness as well. So because it's a system approach, it will include charities and the resources charities have at the moment.
Go ahead, Rebecca.
I think also in response to Phil, we do try to get leaflets into clinics so that as soon as people get a diagnosis, they can be referred to us. And we work at trying to build relationships with clinics, but it's fair to say we are not in all of them. And that's a sort of ongoing project to make sure we get as much access as possible so people can find us as quickly as possible.
Thank you. Annalisa, did you tell us the time frames? When are you completing the first stage?
Yeah, so as I said, we started in March and it will run 2 years. So early 27, we will have already some dissemination, let's say publication, dissemination tools. So definitely the review of all the practice, the guidance, and the understanding of the challenges through practice. So interviews and a focus group. So yeah, by that time, and early 27, with the provision we get the second grant, we will do this called discrete choice experiment, where you actually ask people what do you prefer in terms of services you need and how to access them, where to access them. So again, co-creating a solution.
So I think it's probably fair to say for one of the challenges with academic research is that the length of time that it does take in order to produce credible evidence, and the need to almost link the importance of what you're doing to what it's going to mean to people longer term. And I guess with my head of the board of PSP trustees, what this will provide to us is evidence that we can use as we try and influence policy, as we're talking to MPs, really solid data that we can talk to as we try and change the situation.
Yes, definitely. That will be one of the first objectives, but also when the solution will be created and we will engage commissioners, they will have, tools they actually they do know they can be implemented in practice.
So they will have tools and evidence to get access to more funding in this area.
Yes, or let's say repurposing the funding that is already used in a better way.
Got it. Yes, it is sometimes hard for those of us who aren't in academic research to see how it actually leads to changes in reality. So
yes,
thank you
definitely.
for that.
No, thank you for the question. So we can provide that understanding.
So Megan, do we have our second speaker
Yeah, we do.
ready, or are we still waiting?
No, Sanjay is
Do you think
here.
now's a good time to?
That sounds great.
Okay, so I'll say a big thanks to Annalisa and to Vicky for taking us through their plans. And we look forward to an update sometime in the next year or so on where you're heading and how we can support, making sure we get the most impact out of what you're doing.
Absolutely. Thank you very much.
Okay, so I will now introduce our second speaker this morning, Professor Sanjay Manohar, who is an associate professor and honorary consultant in the Nuffield Department of Clinical Neurosciences at Oxford University.